Hi, I'm John Gazer in the Department of Family Medicine. Today we're going to be talking about the lower extremity exam. I'll be demonstrating how you inspect the lower extremity, how you palpate, and then perform passive range of motion of both the hip, knee, and ankle. We'll come back and look at some special maneuvers that look at the knee exam for people that have an injured knee. We won't be doing active range of motion today, so we normally do that after palpation before passive range of motion, and we're going to just want to make a note that we will be skipping the active range of motion in this demonstration. Helping me demonstrate today is Mr. Bill Garant, and thanks for coming back, Bill. We've seen Bill before here. And initially, as with any type of musculoskeletal exam, with inspection, you're looking for things like deformity, swelling, changes in coloration, when people are walking, changes in gait. We're going to start with inspecting the hip, and Bill, I'm just going to ask you to pick up your gown so we can get a look at your iliac crests. I'm just going to locate the iliac crest here on either side of his lower abdomen, and that just gives me a sense that, that he has some symmetry here with his pelvis, and his legs are probably about the same length, that there's no obvious sort of neuromuscular disease that would cause one side to be weak and perhaps lower than the other side. Next, we're going to take a look at his knees. We're going to be looking for any sort of deformity, and commonly with people, you may see a knock knee deformity, or what's called a genu valgus deformity, where the knees are closer together, or a genu virus deformity, or bow-legged deformity, where the knees are further apart. And Bill has fairly normal-looking knees. I'm not going to go ahead and take a look at extension of the hip while he's standing. This is a fairly easy way to do that. So, Bill, if you could just move to the table and I'll hold it up for you. If you could just sort of support yourself here so we don't lose your balance, and try to stand up straight. I'm just going to reach down and support your leg, and I'm just going to extend this back. You would expect this to extend back about 20 or 30 degrees. Thanks, Bill. You can also do that in the prone position. And then once you go ahead and have a seat up here, and we'll go ahead and look at the rest of the hip. Okay. Yeah, if you would go ahead on my back, please. Okay. And please let me know if anything is sore or uncomfortable as we do this. So I'm just going to go ahead and pull your gown up a little bit if that's okay. Yeah. I'm just going to palpate about the pelvis for instability just to be sure there's no pain. So I'm just going to place both hands over the iliac crest and just rock a little bit if there's any pain or anything there. Bill, let me know. Nope. Just going to palpate over the greater trochanter, which is located on the lateral aspect of the thigh, and it's the large bony prominence. See if there's any tenderness there. And is that sore elbow? Okay, good. Now we're going to go ahead and look at the range of motion of the hip. I'm first going to look at flexion. I'm going to flex your hip up and then bend your knee, and we're going to try to flex this as far up in the abdomen as you can. And you should normally get about 130 degrees of flexion here at the hip. And have you straighten your leg out, and then pick your leg up with the knee extended, and then you should normally get about close to 90 degrees of flexion here. And Bill's got good loose hamstrings, so he's pretty limber. Now we're going to go ahead and check for internal and external rotation. So I'm going to bend your hip and bend your knee to about 90 degrees. I'm going to internally rotate the leg, and sort of paradoxically, when you internally rotate the leg, the foot goes to the outside. When I externally rotate the hip, now the foot's going to go to the inside. Okay, any soreness or pain there? Okay, good. I'm going to abduct or abduct the leg at the hip. So I'm going to pull the hip away from the midline. Okay. I'm going to adduct the hip and pull it towards across his body until the pelvis starts to come up off the table, and he's just starting to rotate now, so we'll stop there. Okay. And we're going to go ahead and first just inspect the knee, looking at the patella, at the bony landmarks, both at the normal concavities on either side of the patella and below the knee. And we go ahead and check the range of motion of the knee, first by just extending the knee, and most people can get their knees to close to 160 degrees here. And then extend the knee, and most people can at least get their knees to a neutral position, 0, and many people have a little bit of hyperextension. Up to 15 degrees is normal, and he just has a little bit of hyperextension at his knee here. Okay. Next, we're going to move down to the ankle. And we're going to just, again, inspect the ankle for any obvious deformity, swelling, redness, bruising. And then we're going to palpate the ankle. We're going to palpate the Achilles tendon, the medial malleolus, and the lateral malleolus, and the midfoot for any tenderness or pain. Any of that bothering you, Bill?
No.
Okay, good. So we're just going to assess the range of motion at the ankle. So I'm going to support his leg, and I'm first going to check flexion at the ankle by grasping his midfoot and pointing his foot towards his head to dorsiflex his ankle. I'm going to point it away from his head to plantarflex his ankle. I'm next going to check inversion and eversion. I'm going to support the, I'm going to grasp the foot at the heel. And I'm going to rotate the foot towards the midline. That'll be inverting the ankle. I'm going to rotate it away from the midline. That'll be everting the ankle. Next, I'm going to check abduction and abduction of the foot. So I'll first abduct the foot by moving the foot away from the midline. And then I'm going to adduct the foot and move it toward the midline. I'm going to come back and look at the knee now to say if Mr. Grant was presenting with a painful knee, and we sort of take a look at the knee a little more closely. First, we'll just, again, look at the knee, and then palpate it. And we'll palpate the patella for any tenderness or discomfort. And palpate the lateral joint line at the tibiofemoral joint. I'm looking for any pain or bony abnormality, then also in the medial aspect of that joint. I want to palpate the tibial tuberosity, and then the popliteal space behind the knee. And there aren't any abnormalities there. Now, some people with an injury might have an effusion in the knee. And I'm going to do a couple of tests now to assess to see if there was any fluid in Bill's knee. I'm going to put one hand over the suprapatellar pouch, and because the knee joint space actually extends up above the patella into the distal leg, and that's called the suprapatellar pouch. And this test is called ballottement. I'm just going to tap on his kneecap or his patella to see if I can drive it back into his femoral condyles. And really, there's really not much give there. And when I let go, if there were an effusion, you'd feel a little bit of a bounce coming back, and there's not, so he doesn't really have any effusion. The other test for effusion is called the bulge sign. And the way you do that is you stroke the medial aspect of the knee between the patella and the femoral condyle, and you try to push the fluid up into the suprapatellar pouch. So I'm just going to firmly push a few times to try to milk any fluid that might be present from the medial aspect of the knee up into the suprapatellar pouch. And I'm just going to take my other hand and push on the lateral aspect of the knee between the patella and the femoral condyle or the epicondyle, and just see if there's a bulge on the other side, on the medial aspect of the knee. And there's not. So he doesn't have any fluid in his knee. The next thing I'm going to do is test for any instability of either the lateral collateral ligament or the medial collateral ligament. And the way you do this is you want to put different stresses on the knee, and we'll start with the lateral collateral ligament. I'll just have you bend your knee about 30 degrees, and then with any exam, you want the patient to be as relaxed as possible. But this is probably particularly important if people have a painful, if they've injured their knee. You want to take time and be slow and try to get them to relax, and you want to support their leg and let them know before you do anything, so they're not going to try to guard against you. And what I'm first going to do is to apply a varus stress to the knee by pushing laterally with my hand here, at the same time pulling the foot towards me to see if I can open up his lateral joint line. And anything sore or tender there? No. Okay. Good. I'm next going to test the medial collateral ligament by applying a valgus stress. I'm going to push medially here while I'm going to push medially at the knee while I push laterally on his lower leg, again to see if I can open up his medial joint line. Anything sore or tender there? Good. Should be looking for pain or any sort of laxity in the joint, and it's always important to compare the injured joint to the normal joint, and you should typically start the exam with a uninjured joint so you have a sense about what the normal range of motion and the abnormalities about the normal joint before you move to the injured joint. I'm now going to go ahead and do some tests that assess for injuries to the cruciate ligaments. The first test is called the Lockman Test, and to do that you need to support the patient's thigh, and so for people that have small hands, or if it's a particularly large person who has a large thigh, this might be difficult. You want to partly encircle the thigh with your hand just above the knee to support it, and bend it to about 20 to 30 degrees. Then you want to grasp around the lower leg, around the tibia. You want to try to pull the tibia anteriorly to see if there's any laxity in the knee joint. And there will typically be a little bit of motion there, but there should be a good firm end point. And he has a normal exam here. And again, you'd want to compare that to the other side. The other test, which might be easier for some folks, particularly if they have a very large leg, it's called the anterior and posterior drawer test. You can bend the leg to 45 to 90 degrees. And then most folks actually just kind of sit on and stabilize the foot by sitting on it. I'm just going to sit right here. Let me know if anything's painful. And you grab both hands around the leg, around the tibia, and you want to pull anteriorly, checking the anterior cruciate ligament, and also push posteriorly to check the posterior cruciate ligament. Again, you're looking for any pain or laxity of motion here, and this is a normal exam. And again, to compare the other side is important. The final exam we'll do is called the Mcmurray Test. That's a test for a meniscal injury. And to do that test, you're looking for inability to extend the leg at the knee, or any pain or popping when you do this maneuver. And to do the maneuver, you need to encircle the anterior part of the knee. So your palm needs to go over the kneecap, and either your index or your middle finger and your thumb have to go over both the medial and lateral joint lines here. And I'm going to bend your knee up all the way. And you want to turn the lower leg, you want to turn the foot medially, and then extend the knee, looking for any pop or crepitus. Any trouble there? No. Okay. And then you want to rotate the foot laterally and do the same maneuver. Just extend the leg, feeling for any crepitus or pop here. Okay, good. So, good knees, Bill. Thank you. Okay. So again, we've examined both the hip, the knee, and the ankle by inspection, palpation, and then passive range of motion, although you'd also want to include active range of motion in a musculoskeletal exam. We also did some special maneuvers to look at ways to assess for knee injury. I'd like to thank Bill for helping out today. Sure. Thank you.